Hello everyone, I hope you're all doing okay. In this video, we will be talking about the third, fourth, and the sixth cranial nerves, which are called the oculomotor, the trochlear, and the abducent nerves, respectively. Now, they all innervate some common structures, such as the extraocular muscles, which are present inside the orbital cavity. And since they have to reach a common destination, therefore they share a common pathway as well. And that is the reason why I'm going to discuss all these three nerves together simultaneously. So, as part of this lesson, first we'll talk about the pathway of the third, fourth, and the sixth cranial nerves. Next, we'll learn about the nuclei, which give off different neurons contributing to these three cranial nerves. Then we'll talk about the structures innervated by these three nerves. Next, we'll talk about the functions of the cranial nerve nuclei contributing to the formation of these three nerves. By doing so, we will understand automatically the functions of the cranial nerves as well. Lastly, we'll apply this information clinically to understand the clinical deficits associated with the lesions of these nerves. Now, prior to listening to any of my videos on the cranial nerves, I would highly recommend that if you haven't done it so far, then first listen to my seminal lecture on the brainstem and the cranial nerve nuclei, which will provide you with a solid foundation to build further on your knowledge of the cranial nerves. The link for that lecture is provided below in the comment section. Now, while describing each cranial nerve in this lecture and in the subsequent ones, I'll be using this table as a reference point to find out which cranial nerve nuclei contribute to the formation of which cranial nerves. And then we'll be building upon our description of each cranial nerve from over there. Also, I'll be using this picture as a reference point, which is nothing but a pictorial representation of the same table over here. What the picture shows is a view of the back of the brain stem over here. You can see the back of the midbrain over here, which is characterized by the two superior colliculi and the two inferior colliculi. These lobulated elevations at the back of the midbrain, these are known as the colliculi. Then you can see the back of the pons over here, and you can see the back of the medulla oblongata, and you can see the floor of the fourth ventricle, the diamond-shaped fourth ventricle, which is clearly visible over here. Then you can see that the cranial nerve nuclei have been overlaid on the brainstem. These have been color coded to match the colors of the columns in the table over here. For instance, you can see the motor columns over here in the red, yellow, and orange coloration, matching with the red, yellow, and orange color in the table over here. Then you can see the sensory columns over here in blue, purple, and green color, matching with the blue, purple, and green color over here. Now, as a first step, let's see where these three cranial nerves originate from the base of the brain. On the left over here, you can see an illustration of the base of the brain showing the ventral aspect of the brain stem over here. For instance, you can see the ventral aspect of the midbrain characterized by these two cerebral peduncles of the midbrain. So this region in the center over here is the intrapeduncular fossa. And you can see the oculomotor nerve over here popping out clearly from the intrapeduncular fossa. The level where the oculomotor nerve pops out from the midbrain is the level where the superior colliculus is situated. So it pops out basically from the upper part of the midbrain from the intrapeduncular fossa. Now on the right over here, you can see a similar view of the prosection of the brain. You can see the pons, the ventral aspect of the pons clearly visible over here, and then the ventral aspect of the medulla clearly visible here. The inferior surfaces of the temporal lobe can be seen over here as well, and that is the inferior aspect or the orbital surface of the frontal lobe, clearly visible here. The ventral aspect of the midbrain is not really clearly visible because it's kind of covered over by these vessels, so its ventral view is kind of obscured by these vessels, but you can clearly see the oculomotor nerve on the left and on the right popping out from the ventral aspect of the midbrain from the intrapeduncular fossa. This is actually a ventral view of the prosection of the brainstem. You can see the two peduncles of the midbrain over here. So this would be the region called the intrapeduncular fossa. The peduncles are a little bit broken here, but you can still appreciate the peduncles. And oculomotor nerve can be seen very nicely popping out from the intrapeduncular fossa on the right side and on the left side. Then this is the ventral aspect of the pons, which corresponds with the ventral aspect of the pons over here. You can see the basilar groove over here. The basilar groove is kind of visible visible here as well. And this is the ventral aspect of the medulla, and which corresponds with the ventral aspect of the medulla oblongata in this illustration over here. Then the fourth cranial nerve, which is the trochlear nerve, that pops out from the midbrain as well. However, this is the only cranial nerve which comes from the back of the midbrain. So after originating from the back of the midbrain, it basically travels on the side of the midbrain and then comes to lie on the ventral aspect, share a common pathway with the oculomotor nerve. And hence you can imagine that the trochlear nerve is going to have a fairly longer course as compared to the oculomotor nerve, as it's coming off from the back of the midbrain and then coming on the side and then coming to the front of the midbrain here. So that's our fourth cranial nerve, which is the trochlear nerve. The trochlear nerve is not clearly visible on the prosection over here because it's fairly small nerve. It's hard to identify compared to the oculomotor nerve, which is much more wider in its diameter and comes up from the front as well, so it's clearly visible on the prosection. Lastly, we've got the abducent nerve, which is our sixth cranial nerve, and that basically originates from the junction of the pons and the medulla oblongata from the ventral aspect of the brain stem. And if you look over here, you can see this is the abducent nerve. So basically, if we go from the midline and make our way laterally, then we've got three cranial nerves over here, the abducent followed by the seventh and the eighth cranial nerves. We'll talk about those nerves later, but you can see that the abducent nerve is originating at the junction of pons and medulla and is the medial most nerve in this group of three nerves over here, which all originate from the junction of pons and the medulla. Now that we know about the origin of these three cranial nerves from the base of the brain, let's see how they travel all the way anteriorly to the orbital cavity to reach out to the extraocular muscles around the eyeball. So just to briefly outline the course of these nerves for you, following their exit from the base of the brain, these nerves, they travel through the cavernous sinus, which is one of the important venous sinuses in our cranial cavity. Then they pass through a bony fissure, which is called the superior orbital fissure, and eventually they reach the orbital cavity to innervate the extraocular muscles. We will be describing the location of the passage of these nerves through each of these anatomical stations one by one. Now here on the left, you can see an image of the cranial cavity. This bony region over here, this is known as the clivus, which is formed by the basilar part of the occipital bone resting on the back of the body of the sphenoid bone. So this region here is the body of the sphenoid bone. This region here is known as the clivus. The ventral aspect of the brain stem is going to rest against this bony clivus. So the pons and the medulla would be resting right against this bony clivus over here. This bony region over here, this is known as the sella turcica, which is the top part of the body of the sphenoid bone, which is going to house the pituitary gland inside it. There are two venous sinuses present on either side of the sella turcica and the pituitary gland. These are known as the cavernous venous sinuses. The nerves, when they pop out from the base or the ventral aspect of the brainstem, they are going to travel forward on either side of the sella turcica, shown by these yellow lines over here. That's the course which the nerves are going to adopt when they pop out from the ventral aspect of the brainstem, passing on either side of the sella turcica through the cavernous sinuses. Now, if we take a coronal or a side-to-side section through the cavernous sinuses, then the section would look somewhat like this over here. So what you can see over here is a section of the body of the sphenoid bone, and you can see the sphenoidal air sinuses inside it. On top of that, this is the area called the sella turcica, which is housing the pituitary gland. But just remember that you are looking at the section from the front now, which means basically from this side over here. So you're looking at it from the front over here. Therefore, you can see the pituitary gland kind of related superiorly and anteriorly to the optic nerves over here. The optic nerves are going to cross over here at the region called optic chiasma, and then the optic tracts are going to be at the back. We're looking at the section from the front, so hence we can see the optic nerves and not the optic tract. Therefore, this section over here, which represents a section of the cavernous sinus, that is actually the left cavernous sinus over here. The right one is going to be on the other side of the body of the sphenoid bone. Several nerves can be seen passing through the cavernous sinus. The oculomotor nerve and the trochlear nerve, which means the third and the fourth cranial nerve, they can be seen passing through the lateral wall of the cavernous sinus, in addition to obviously the ophthalmic maxillary divisions of trigeminal, but we're interested in the oculomotor and trochlear for now. On the contrary, the sixth cranial nerve, which is the abducent nerve, that actually passes through the venous sinus itself. So it's literally passing through the blood inside the venous sinuses. And as it passes through the cavernous sinus, it is related antero-inferiorly to the internal carotid artery. Now, this is an important anatomical location or an important anatomical relation to know, because if there's any problem inside the sinus, such as a rupture of the aneurysm of the internal carotid artery over here, then the abducent nerve is more likely to be affected or compromised first as compared to the oculomotor and the trochlear nerve. This information might actually help you in the lesion localization. Now, after exiting through the cavernous sinus, these three cranial nerves, they will pass through a region which is known as the superior orbital fissure. The superior orbital fissure is a slit-like space which is bounded superiorly by the lesser wing of the sphenoid bone, which you can see at the top over here, while its inferior margin is formed by this greater wing of the sphenoid bone. You can't really see the superior orbital fissure clearly over here because the lesser wing of sphenoid bone is obscuring your view. The fissure would be situated between the lesser and the greater wings of the sphenoid bone. Now, this is a magnified view of the superior orbital fissure, and you're looking at the superior orbital fissure from the side of the cranial cavity, which means you're looking at it from the back. So you're looking over here from this side over here. So that means that this would be the lesser wing of the sphenoid bone at the top. This would be the area where the greater wing of the sphenoid bone would be present. And on the medial side, we can see the body of the sphenoid bone, which is this region over here. So you can see that the superior orbital fissure is situated within the sphenoid bone, bounded superiorly by the lesser wing, laterally by the greater wing of sphenoid bone, and medially by the body of sphenoid bone, as shown over here as well. The body on the medial side, the lesser wing at the top, and the greater wing on the lateral side over here. This impression of the circular ring, which you can see over here, is actually an impression of the common tendinous ring, which is actually attached on the superior orbital fissure, but on the side of the orbital cavity, which means that you're going to be able to see this common tendinous ring when you look at the superior orbital from the front, from the side of the orbital cavity. The cranial nerves pass from the cranial cavity through the superior orbital fissure, passing through the common tendinous ring and enter into the orbital cavity. Now, some of the cranial nerves, they pass through the common tendinous ring, whereas other cranial nerves, they basically go through the superior orbital fissure but outside the common tendinous ring. For instance, the oculomotor nerve, which is our third cranial nerve, that passes through the common tendinous ring along with the abducent, which is the sixth cranial nerve. Whereas the trochlear nerve, the fourth cranial nerve, that passes through the superior orbital fissure outside the common tendinous ring. There are other structures as well, which you can see here. For example, the superior and the inferior ophthalmic veins, which you can see going through the superior and inferior orbital fissure outside the common tendinous ring. And similarly, you can see the lacrimal and the frontal and the nasociliary branches of the trigeminal nerve as well, which we will talk sometime later. The lacrimal and frontal branches of the ophthalmic division of trigeminal, they pass outside the common tendinous ring, whereas the nasociliary branch of the ophthalmic division, or the V1 division of trigeminal nerve, that passes along with the oculomotor nerve through the common tendinous ring as it passes through the superior orbital fissure to enter into the orbital cavity. Now here you can see the anterior part of the cranial cavity, and you're looking at the cranial cavity from the top over here. See the orbital plate. See the orbital plate of the frontal bone on the right side over here has been taken off. It has been chipped off, and you can see the eyeball and the extraocular muscles residing inside the orbital cavity. This is the region where the lesser wing of the sphenoid bone is going to be present, and you can see that a little bit of the lesser wing of the sphenoid bone has been chipped off over here, so you can actually see the superior orbital fissure partly over here, which was initially hiding underneath the lesser wing of the sphenoid bone. This yellow arrow over here is a schematic which shows you the passageway of the third, fourth, and the sixth cranial nerves as they pass through the superior orbital fissure, entering from the cranial cavity into the orbital cavity. So eventually inside the orbital cavity, These cranial nerves are then going to innervate structures such as the extraocular muscles and structures inside the eyeball such as the iris and the ciliary muscle. Now that we know about the origin and the course of the oculomotor, trochlear, and abducent nerves, how about if we talk about the nuclei associated with these three cranial nerves? These nuclei, which are all motor, give off motor neurons or the efferent neurons, which then run through the nerves and eventually end up supplying the extraocular muscle, the iris, and the ciliary body. You can simply think of the nerve as a huge pipe, and there are several different cables running through that pipe. These cables are in fact the neurons, which have come off from different cranial nerve nuclei. So coming back to our reference table and reference figure over here, if you look at the oculomotor nerve, the table suggests that the oculomotor nerve highlighted in red over here, the table suggests that the oculomotor nerve is a pure motor nerve. It has two nuclei, both motor, one situated in the general somatic efferent column or the red column over here, and hence it will innervate a somatic structure which is under our voluntary control, and those would be the extraocular muscles. The other nucleus is the autonomic nucleus, which is present in the yellow column over here, which is the general visceral efferent column, or the column which contains the parasympathetic nuclei. This nucleus is known as the Edinger Westphal nucleus. The illustration over here shows the posterior aspect of the midbrain, where you can see the superior colliculi and the inferior colliculi. These are the lobulated swellings present at the back of the brain. Both the oculomotor nucleus, shown in red, and the Edinger Westphal nucleus, shown in yellow over here, are situated in the upper half of the midbrain at the level where the superior colliculus is situated. Then if we look at the trochlear nerve, the table suggests that the trochlear nerve is also a pure motor nerve. It has only one nucleus, which is situated in the red column, which is the general somatic efferent column, and hence it will also innervate a somatic structure which is under our voluntary control, and that somatic structure would be an extraocular muscle called the superior oblique muscle. Once again, in the illustration over here, you can see the posterior aspect of the midbrain with the superior and the inferior colliculi over here. The trochlear nerve nucleus is present inside the midbrain, but in the lower half of the midbrain at the level where the inferior colliculi are present, unlike the oculomotor nuclei and the Edinger Westphal nuclei, which were situated in the upper half of the midbrain where the superior colliculus was situated. Lastly, if you look at the abducent nerve over here in the table suggests that the abducent nerve is also a pure motor nerve. It has only one nucleus, which is situated in the general somatic efferent or the red column over here, and hence will innervate a somatic structure which is once again under our voluntary control. And in this case, this would be the lateral rectus muscle, which is also an extraocular muscle. Here in the illustration, you can see the posterior aspect of the pons. You can see the floor of the fourth ventricle, which is this diamond-shaped space over here. You can see that very nicely. The pons is the anterior relation of the fourth ventricle, along with the medulla oblongata down below. The abducent nucleus is this red-colored nucleus, which can be seen situated close to the midline in the pontine region. Now, as discussed before as well, the structures innervated by these nuclei include the extraocular muscles, the iris, and the ciliary body or the ciliary muscle. Now, before we start describing things in detail, we can use this schematic to understand the relationship of the cranial nerve nuclei, the neurons, the nerves through which these neurons run, and the structures which are innervated by these nuclei or the neurons. So you can see a schematic which shows the oculomotor nerve in yellow over here. That oculomotor nerve, which is our third cranial nerve, has two types of nuclei: the general somatic efferent nucleus, which is the oculomotor nucleus, and general visceral efferent nucleus, which is the Edinger Westphal nucleus. Remember, this is the parasympathetic nucleus. So therefore, there would be two types of neurons running through the oculomotor nerve. We'll have somatic efferent neurons, and we'll have general visceral efferent or the autonomic neurons. These neurons, they travel through the oculomotor nerve to eventually reach up the orbital cavity, where they end up supplying the structures such as extraocular muscles, which are supplied or innervated by the somatic efferent neurons. And then we've got iris and the ciliary muscle, which are innervated by the autonomic neurons. The parasympathetic autonomic neurons coming from the general visceral efferent or the Edinger Westphal nucleus. Then we've got the trochlear nerve over here, In the trochlear nerve, you can see that it has only one type of neurons running through it. Those are the general somatic efferent neurons coming from the general somatic efferent nucleus, which is in this case is the trochlear nucleus. These general somatic efferent neurons running through the trochlear nerve eventually reach up the orbital cavity to innervate only one muscle, which is the superior oblique muscle, which is, we all know by now, an extraocular muscle. Then we've got the abducent or the sixth cranial nerve, which also is a pure motor nerve and has only one type of nerve fibers or neurons running through it. Those are once again the general somatic efferent neurons coming from the general somatic efferent nucleus called the abducent nucleus. These neurons, they travel through the abducent nerve to reach the orbital cavity to innervate one extraocular muscle, which is the lateral rectus muscle. Now let's take up the oculomotor nucleus first. The motor efferent neurons from the oculomotor nucleus, they travel through the oculomotor nerve and innervate the levator palpebrae superioris muscle and the four extraocular muscles, namely the inferior oblique, the medial rectus, and the superior and the inferior recti muscles. I've enumerated the individual actions of these extraocular muscles in the table over here, and we'll make a separate video on the eye movement sometime later to talk about the individual actions in detail and the axes around which these actions happen. However, that is beyond the scope of this lecture. So for now, you can actually use this pictorial mnemonic to memorize the movements and actions of the extraocular muscles. In this mnemonic over here, this is the nasal side. So that's the side where the nose is going to be present. And this is the temporal or the lateral or the outer side over here. The muscles innervated by the third cranial nerve include the inferior oblique muscle, the superior rectus muscle, the medial rectus muscle, and the inferior rectus muscle. Now, if you look at this pictorial mnemonic, you can see that the inferior oblique brings about three actions. It causes adduction of the eyeball, so medial deviation of the eyeball. It causes extorsion, and it causes elevation of the eyeball as well. Similarly, superior rectus brings about three actions, and those are the elevation of the eyeball, the medial deviation or the adduction of the eyeball, and then the intorsion as well. The medial rectus is a pure adductor of the eyeball. The inferior rectus brings about three actions as well. Those are the adduction of the eyeball, the depression of the eyeball, and it causes extorsion as well. So if there's a lesion of the third cranial nerve, then the actions of the remaining two muscles, that is the superior oblique muscle and the lateral rectus muscle, will become uninhibited or unmatched. You can see that the superior oblique causes depression and abduction of the eyeball, while the lateral rectus is a pure abductor of the eyeball in any case, and hence in case of a third cranial nerve palsy or lesion, the eyeball would get deviated downwards and outwards. Now, the other nucleus which contributes to the third cranial nerve is the Edinger Westphal nucleus, which is an autonomic parasympathetic nucleus, and the motor neurons emerging from it will innervate autonomic or visceral structures, which in this case are the iris and the ciliary muscle. And you probably know by now that the autonomic motor pathway is divided into a preganglionic segment and into a postganglionic segment. The Edinger Westphal nucleus gives rise to the preganglionic parasympathetic neurons, which synapse with the cell body of the postganglionic neurons inside the ciliary ganglion, which is situated inside the orbital cavity. The postganglionic neurons then innervate the ciliary muscle and they innervate the sphincter pupillae muscles of the iris. Now, the contraction of the sphincter pupillae muscles of the iris will lead to constriction of the pupil, a phenomenon which is known as the miosis. This can be elicited by checking for the light reflex. So you see, when we shine the light into the eyes, then it causes the pupil to constrict. The sensory information with regards to this extra light which is being shown into the eye is carried via the visual pathway neurons to the midbrain, where the Edinger Westphal nucleus is situated. The Edinger Westphal nucleus then initiates a motor response by causing constriction of the sphincter pupillae muscle of the iris using this autonomic pathway which we have just described. The second structure innervated by the Edinger Westphal nucleus is the ciliary muscle, and the contraction of the ciliary muscle helps in accommodation for near vision, which helps you in activities such as reading, writing, and so on, where you need to focus on close by objects. Right, so how does a patient present if he or she has an oculomotor paralysis or a palsy of the third cranial nerve? An etiological example could be, let's say, there's a space occupying lesion such as a subdural venous hematoma or an epidural arterial hematoma inside the cranial cavity, which can lead to transtentorial herniation. For instance, if you look over here, you can see a coronal or a side-to-side section taken through the brain and through the cranial cavity. You can see the midline partition of the dura mater over here separating the two cerebral hemispheres from each other. And then you can see a partition, a horizontal partition of the dura mater, which is called the tentorium cerebellum, and that is separating the cerebral cortex at the top from the brainstem cerebellum down below. And the midbrain is passing through a little gap inside the tentorium cerebellum, which is known as the tentorial notch. Now, in this coronal section, if you see over here, there is an epidural hematoma, an arterial hemorrhage over here, which occupies a lot of space at a very short interval of time in an acute fashion. And this is going to push the cerebral cortex down below over here, pushing the midbrain through the tentorial notch over here. Now, as the midbrain gets pushed over here through the tentorial notch down below from the supratentorial compartment to the infratentorial compartment, part of the cerebral cortex or part of the temporal lobe, which is present medial close to the midbrain, which is also known as the uncus, that also gets pushed over here through the through the tentorial notch, and this is known as the uncal herniation, which causes the transtentorial herniation of the midbrain. And this results in not only the compression of the midbrain, but it causes a stretching of the third cranial nerve and consequently a lesion of the third cranial nerve as well. So here in the picture over here, you can see the midbrain, a horizontal section of the midbrain with the two rabbit ear-like projections over here called the crura cerebri. And this is the intrapeduncular fossa, so that is the anterior aspect of the midbrain. And you can see the two cranial nerves. You can see the two third cranial nerves or the oculomotor nerves popping out from the intrapeduncular fossa. This is the gap which is known as the tentorial notch. And now in this case over here, you can see the compression of the midbrain, where the midbrain is being pushed through the tentorial notch along with the uncal part of the temporal lobe, and consequently they get compressed over here as a result of that transtentorial herniation because of this epidural arterial hematoma, for instance. Now, such a patient could actually present with diplopia. Diplopia is also known as the double vision, and here, since the eyeballs are not going to be aligned anymore because of the paralysis of the third cranial nerve, the extraocular muscles would actually get paralyzed, and so therefore the alignment of the eyeballs on both sides is going to be lost, and that would result in the diplopia or double vision, especially when the patient looks in the direction of the parotic muscle. Now, the denervation of the extraocular muscle causes the eyeball to look down and out because, as we already discussed, the actions of the lateral rectus muscle innervated by sixth cranial nerve and the action of the superior oblique muscle innervated by the fourth cranial nerve, they would get unimpeded or uninhibited because of the paralysis of all these muscles over here, which are innervated by the third cranial nerve. This causes the eyeball to deviate down and out. Then we also know that the third cranial nerve innervates the levator palpebris superioris muscle. One of the actions of the levator palpebris superioris muscle is to pull the eyelid up, and consequently a lesion of the third cranial nerve will lead to paralysis of this muscle, thus leading to dropping of the upper eyelid, which is also known as the ptosis. Lastly, the interruption of the parasympathetic innervation through the Edinger Westphal nucleus because of the lesion of the third cranial nerve results in a dilated and fixed pupil. So there won't be any response to the light reflex. The constriction of the constrictor pupillae muscles of the iris would be lost, resulting in a dilated fixed pupil. Plus, there would be paralysis of accommodation, and there would be inability to accommodate for the near vision because of paralysis of the ciliary muscle, and that is known as the cycloplegia. Now let's take up the trochlear nucleus. This is a motor nucleus, and it is general somatic efferent in nature. It gives rise to general somatic efferent neurons which travel through the trochlear nerve to innervate one extraocular muscle, which is the superior oblique muscle. The actions of the superior oblique muscle could be understood by this pictorial mnemonic over here. So you can see that the superior oblique muscle produces lateral rotation of the eyeball, which happens along a vertical axis. It causes intorsion, which happens along an anteroposterior axis. So it kind of moves the eyeball inwards along an anteroposterior axis. So it causes intorsion and it causes depression. And this movement of depression happens along a transverse axis. So the superior oblique muscle basically causes the eyeball to look down and out. Now, a lesion of the trochlear nerve nucleus or the trochlear nerve will therefore result in an inability or a difficulty to look down and out. The patient, for instance, might complain of difficulty, let's say moving down the stairs or similar activities where they have to look downwards. Also, we could see a vertical diplopia, which increases when looking downwards, unlike the oculomotor nerve paralysis, where there was a horizontal diplopia. Because remember, one of the actions of superior oblique muscle is to cause depression. So when you ask the patient with a superior oblique paralysis or a trochlear nerve palsy, if you ask this patient to look downwards, then the diplopia would become more prominent. Now, another clinical finding which we can find in a patient with a trochlear nuclear or trochlear nerve palsy is that the patient's chin will be tilted towards the side of the lesion. So, for a trochlear nerve palsy of the right side, the chin will be deviated towards the right side as well. Now, let's try to understand the reason behind it. First, you have to understand what are the intorsion and extorsion movements of the eyeball. So if you look at this cartoonic illustration over here, you can see this is a cartoonic illustration of the eyeball with an anteroposterior axis passing through the eyeball. You can see this is the nose drawn over here. So this is the medial or the nasal side, and this would be the outer or the lateral side. So you're basically looking at the left eyeball from the front. Now, if this is the anteroposterior axis of the eyeball, then the eyeball can either deviate inwards, can rotate inwards, which is known as intorsion along the anteroposterior axis, or it can rotate outwards along the anteroposterior axis, and this movement is known as the extorsion. So intorsion is the rotation of the eyeball inwards along the anteroposterior axis, and extorsion is the rotation of the eyeball outwards along the same anteroposterior axis. Now see, here's a patient with a normal right eye with no infarction or lesion of the trochlear nerve or the trochlear nucleus. Therefore, in this patient, when she tilts the chin to the right side or the head to the left side, then there's a compensatory extorsion of the right eye or outward rotation of the right eye along an anteroposterior axis, and there's a compensatory intorsion of the left eye or inward rotation of the left eye along the same anteroposterior axis, so as to maintain the focus on the objects in the environment. And since both the eyes are perfectly aligned with each other, their axes are perfectly aligned with each other, therefore there is going to be no diplopia or double vision. Now, if the same patient suffers from an infarction or a lesion of the fourth cranial nerve or the nucleus, let's say on the right side over here, then that would actually cause the right eyeball to become slightly elevated and extorted. So remember that one of the actions of superior oblique muscle was that it was causing depression of the eyeball, and now this depression would not be there anymore, and therefore the elevation action of inferior oblique would not be counteracted, and so the eyeball consequently would be a little bit elevated because of the paralysis of the superior oblique muscle. And also one of the action of superior oblique muscle was to cause intorsion or inward rotation of the eyeball along the anteroposterior axis. And since this muscle has been paralyzed, so the extorsion action of the inferior oblique is not counteracted anymore, and consequently the eyeball would be rotating outwards along the anteroposterior axis. So in other words, the eyeball is slightly elevated and it is extorted or rotated outwards a little bit. Now, this would naturally result in a misalignment of the anteroposterior axes of the eyeballs, and therefore this would lead to a diplopia or a double vision. And this diplopia or double vision would become even more prominent when the patient is asked to look downwards, because that is one of the actions of the superior oblique muscle. Superior oblique muscle is not working anymore, and the diplopia would become much more prominent. That is a vertical diplopia. So what does the patient do? Well, the patient basically tilts his or her chin to the right side, or the head to the left side. So by tilting the chin to the right side, the patient is basically compensating for the extorsion of the right eye, because the chin is actually deviated to the right side, and by doing so the eyeball automatically turns back to its original position. And now the left eye, what it does is that the superior oblique muscle on this side is still intact. So the superior oblique muscle on this side is then going to contract and bring about a compensatory intorsion of the left eye to balance for the extorted movement of the right eye. And this eventually results in the axes of the both eyeballs to align with each other, and thus resulting in the disappearance of the diplopia. So the patient basically compensates for this diplopia by tilting his or her chin towards the side of the fourth nerve lesion. Lastly, let's take up the abducent nerve nucleus, which is basically a general somatic efferent nucleus, which gives off general somatic efferent neurons, which then travel within the abducent nerve and eventually innervate an extraocular muscle called the lateral rectus muscle. The lateral rectus muscle pulls the eyeball outwards or laterally, and that is the reason why when there is a lesion of the abducent nucleus or abducent nerve palsy, then that results in a convergent strabismus. So what you can see over here is a picture of a patient who has a paralysis of the lateral rectus muscle on the left side, or a sixth nerve palsy on the left side. Consequently, the eyeball is deviated inwards because of the unimpeded action of the medial rectus, which pulls the eyeball onto the medial side. This results in a convergent or an inward strabismus of the left eye. Now, in this case, there would be a horizontal diplopia, unlike the superior oblique paralysis where we actually saw a vertical diplopia. So if you look over here, if the same patient who has a paralysis of the sixth nerve on the left side is asked to look to the right side, then there won't be any diplopia seen in this case, because the lateral rectus on the right side is intact. There is no sixth nerve palsy on the right side, and the third nerve on the left side is intact as well, and the medial rectus can perfectly contract and pull the eyeball on the inside. So there is no misalignment of the axes of the two eyeballs, and therefore there is no diplopia. However, if the same patient is asked to look now to the left side, then we know that there is a paralysis of the abducent nerve over here, and so the lateral rectus on this side is not going to function. So the eyeball cannot be deviated outwards, and consequently, when the medial rectus over here pulls the eyeball on the inside, and the lateral rectus over here is not able to do that, and so consequently what you see is that the two axes of the eyeball misalign, resulting in a diplopia. And this would be an example of horizontal diplopia as a result of the abducent nerve paralysis. So thank you very much for listening to this video. I hope you benefited from this video. If yes, then please do like the video and don't forget to subscribe to the channel. Until next time, goodbye.